So our first speaker this afternoon is Dr. Christopher Paciullo, and Dr. Paciullo is a clinical pharmacy specialist in cardiothoracic surgery and critical care, as well as the residency program director for the PGY1 residency at Emory University in Atlanta, Georgia. He also holds an appointment as an adjunct clinical assistant professor at Mercer University College of Pharmacy, as well as Emory University School of Medicine. He graduated from the University of Rhode Island College of Pharmacy and completed a PGY1 residency at St. Joseph's Hospital in Lexington, Kentucky, followed by a PGY2 residency in critical care at the University of Kentucky. Dr. Paciullo is the past chair of the ACCP Critical Care PRN and currently co-chairs the ACCP SCCM ASHP Task Force on Critical Care Pharmacy Services. His current areas of interest are pharmacotherapy surrounding extracorporeal support devices, advanced hemodynamics, and renal replacement therapy. So thank you, Dr. Paciullo.
Thank you, Dr. Smith. All right. Thank you all for coming back after lunch on such a beautiful day. I applaud your motivation. I have no conflicts of interest. These are the things that we're going to go over today. Basically, we're going to take the world of critical care and sum it up in about an hour. So these are the kind of the bread and butter topics that I like to go over during this talk, and intermixed throughout, we're going to have a lot of different cases. I have an anti-agenda. These are the things we're not going to talk about because I could spend well over an hour on each one of these different topics, but I do give you some resources, as well as these things are in the book chapters. So acid base, we can spend a lot of time on. There's a great website out there that will give you some information on how to determine acid-base disorders, as well as I tell my students and residents all the time to use YouTube. If you're a visual learner, which a lot of you probably are, that's why you're here, using YouTube for different things that are hard to understand, that you want to see it really in pictures, is a great place to look. We're not going to really talk about ACLS other than a few very important topics. Anything that requires memorization, lab values, etc., we're not going to talk about, nor are we going to talk about clinical trials. So let's get started with one of my favorite topics, which is hemodynamics. And I tell everyone that what we do in critical care is really optimize oxygen delivery. So we do that usually via manipulation of cardiac output. So cardiac output is how much blood your heart pumps out in a minute. And it's determined by two main factors: heart rate, which is dependent on your sympathetic and parasympathetic nervous system, and stroke volume, which is the amount of blood that comes out with each beat. Stroke volume is further influenced by preload, afterload, and contractility, or really how well your pump works. So we're going to talk about the other two in a little bit more detail. So as far as preload go, preload is really how much blood is in the ventricle before ejection. And preload, there's a few different ways that we can measure it. There's things that are called static markers, which are really less accurate, things you've probably heard about a lot, like central venous pressure, pulmonary artery occlusion pressure, pulmonary capillary wedge pressure, as well as dynamic markers, which are a little bit more accurate, stroke volume variation, pulse pressure variation, which require specialized equipment that aren't available in all centers. A lot of us probably want to forget the Starling curve that's on the right-hand side. So as stroke volume, or as preload goes up, so does stroke volume to a point. Different things affect preload. So things like intravascular volume status. So how much circulating volume do you have, and how well is that venous blood being returned? As well as atrial contraction. So as we'll see in a second, our patients with, say, atrial fibrillation can't really fill their ventricle and therefore have a hard time maximizing their preload. Well, what about blood pressure? We focus a lot about blood pressure in critical care. So afterload and blood pressure are related, but they're not the same thing. Afterload is really resistance to flow. It's better as a concept than it is an actual number that we refer to as SVR, systemic vascular resistance. Blood pressure is really an indicator of global perfusion pressure. So what is perfusion pressure? Perfusion pressure is essentially, that doesn't jump that well, okay, is essentially a marker of blood flow into tissues, and all of your different tissues operate on this curve. In the middle, your tissues are very good at regulating blood flow across a range of perfusion pressures. But when you get to the left-hand side of that curve, you start to see blood flow drop off. And when a perfusion pressure drops off, then you get ischemic tissue. For example, your brain likes a perfusion pressure somewhere in the 40s. Therefore, a mean arterial pressure, once that drops below 65, which is our magical number for a lot of the times, you start to see reduced blood flow to the brain and a lot of bad outcomes. We measure blood pressure directly via usually an arterial line. So how do we know whether or not somebody has good oxygen delivery or not? There's a few different things you can look at. The most simple are just end organ perfusion. Is the patient mentating? Does the patient have a good urine output? Is their creatinine going up? Are their LFTs going up? Do they feel cold? Are they diaphoretic? Things like that. We can measure it as well, so we can measure things like lactate or lactic acid, which is a measure of anaerobic metabolism. Venous oxygen saturation, SVO2 or SCVO2, is another measure that we can look at. And normally, your SCVO2 right now, hopefully, all of you in this room, is somewhere around 75%, meaning that you're consuming about 25% of the oxygen that's being delivered to your tissues. The more abnormal that number gets, up or down, the worse it is for your tissues. So when you see the SCVO2 go up, that means that you have decreased utilization. Classically, we see this in sepsis. Or your SCVO2 goes down, meaning that you're delivering a less amount of blood to the tissues, so the oxygen that your tissue is seeing, it's going to take more of than normal. So that brings us into shock, and there's a lot of different types of shock. These are the four main things that we think about. So septic shock, hypovolemic or hemorrhagic shock, cardiogenic shock, and obstructive shock. And in the workbook, there's in Table 2, there's a very detailed explanation of each one of these. So let's start off with our first case. So we have a 74-year-old female who's post-op day 2 after a double valve replacement. She's doing well until this morning when she went into AFib. Her vital signs you can see up there: heart rate's 145, her blood pressure is a little low, her cardiac index is down, and her SCVO2 is also down. So what is the best pharmacologic intervention to improve her oxygen delivery? Give her dobutamine, give her some intravenous fluids, give her amiodarone, or give her nicardipine. So the answer here, and I encourage you not to cheat and look at the next slide, is amiodarone. So I'll give you some rationale on how we go about thinking about what the answer is. So atrial fibrillation is new for her. She was doing well, and now she's not. A high heart rate can decrease preload. Remember, we talked about atrial contraction and how important that is to get a proper preload. Her blood pressure is okay, but it's a little bit low, and her cardiac index is a little bit low, probably due to her new onset AFib. So if we think about each one of these options independently, dobutamine is going to increase her heart rate. Well, that's not good. LR, not going to do anything for us. There's no evidence that she's actually intravascularly depleted. And nicardipine, her afterload is actually borderline low, so we don't want to decrease her blood pressure any further. Amiodarone, to pharmacologically convert her AFib into sinus rhythm, restore that atrial contraction, is probably our best option. So, big news. We changed the definition of sepsis about 3 months ago now. So your book chapter is outdated, so all of you get the special new information that's in the handouts here. So Table 3 no longer applies. Sorry to upset anybody. So sepsis now, our new definition, is suspected infection plus 2 or more SOFA points, and this is for patients in the ICU. Outside of the ICU, sepsis is now defined as infection plus 2 or more Q-SOFA points, and we're going to talk about what these two things are. There's no more severe sepsis. That doesn't exist anymore, and now we talk about just septic shock. And septic shock is a subset of sepsis defined as hypotension requiring vasopressors and having a serum lactate above 2 despite fluid resuscitation. So here's SOFA. I don't think anybody anticipates or wants you to memorize this whole table, but basically the higher the score, the more organ dysfunction. So a score of 2 or 2 above baseline for some patients with some chronic organ dysfunction. A rise of a SOFA score of 2 indicates poor organ function. And if it's due to infection, we call that sepsis. This is complicated, so the authors of the new sepsis definitions came up with something called QSOFA. You can actually go to qsofa.org and they'll give you more information about this, but essentially to have sepsis outside of the ICU, an easy way to screen for sepsis is having 2 out of 3 QSOFA points. So QSOFA is made up of only 3 things: an altered mental status, defined as a GCS less than 15, a fast respiratory rate greater than or equal to 22 breaths per minute, or low blood pressure, which is systolic less than 100. Infection in 2 or more of these criteria leads you to sepsis. Everything else is the same. Disclaimer, okay? All the resuscitation measures, everything else is exactly the same. So for initial resuscitation, we think of sepsis bundles, and we have both 3-hour bundles and 6-hour bundles. In our 3-hour bundles, there's 4 things that we need to do. We need to measure a lactate level, figure out what is the oxygen delivery. We need to get blood cultures, preferably before we give antibiotics. And we need to administer broad-spectrum antibiotics. This is not the time to be antibiotic stewards. It's time to go with the big guns. And we administer crystalloids for hypotension, so if the patient has a low blood pressure, or that lactate level comes back as greater than or equal to 4. And we'll go with crystalloids first. So within 6 hours of a sepsis individual being diagnosed with sepsis, we're going to maintain a mean arterial pressure above 65, and if we've already given fluids, that's the time to go to vasopressors. We're going to reassess the patient's volume status after we give them fluids, after we give them vasopressors, if their MAP still is low and if their lactate remains elevated. So how we do that is a focused examination, looking to see do they still have cold extremities? Are they still diaphoretic? We can measure CVP at this point. We can measure SCVO2. We can do an ultrasound at the bedside. We can do some of those dynamic assessments that we talked about earlier. And within 6 hours, if that initial lactate level that you measured within 3 hours was elevated, we want to recheck it and see if it's gone down and see if we're doing our job. So we talk about fluid resuscitation. There's a very big debate that goes on for the last 20 years in critical care. Do we give crystalloid or do we give colloid? Crystalloids are generally preferred. They're cheaper. And there's no data that colloids are actually superior in any patient population. So when would you use colloids? Well, maybe considered if you've given a patient 8-10 liters of crystalloid and you're starting to get into some extravascular volume overload. And definitely hydroxyethyl starch, so things like pentastarch, hetastarch, are not recommended by any guideline or any organization anymore due to increased risk of a kidney injury, as well as mortality concerns. We favor balanced crystalloids when we give crystalloids over chloride-rich crystalloids because of a lower risk of kidney injury. So what do I mean by that? So balanced solutions are things like lactated ringers and plasmolite. They have significantly less chloride. They have a higher pH, closer to physiologic pH, less likely to induce metabolic acidosis, and just healthier for the kidneys in general. So let's go to our next case, which is the same patient. 80-year-old female admitted with urosepsis. Her blood pressure is 72/44, heart rate of 120, urine output of 20 mLs per hour, and her labs indicate a serum creatinine of 2.7. So following initiation of appropriate empiric antibiotics, what is the next best step? Give her some vasopressors, give her some furosemide, give her a lactated ringer bolus, or give her a bolus of albumin. All right, looks like I didn't trick anybody with this one. So again, patient with sepsis. Think sepsis bundles. I will admit I forgot to update this where it says septic shock and severe sepsis. Those two don't apply anymore, but she still is hypotensive. So what is your goal? Think about your sepsis bundles. Get that MAP over 65 using fluids. So vasopressors we'd usually only go to after fluids. Lasix is not a good idea for low urine output in somebody who's hypotensive and septic. Crystalloids versus colloids, we prefer crystalloids up front whenever possible. So what about vasopressors and when you have to go to those? So our vasopressor of choice is norepinephrine. It's been studied against dopamine. Dopamine is an alternative. However, dopamine has higher rates of tachyarrhythmias associated with it. If epinephrine by itself isn't effective, we can add epinephrine or vasopressin at a very low dose. And the vasopressin may be more effective at lower doses of norepinephrine. Renal dose dopamine is something that still comes up despite 15 to 20 years of knowing that it doesn't work. This is where that people would give low-dose dopamine in order to increase perfusion of the kidneys. We've known that it doesn't work for a very long time. Other pressors, phenylephrine may be considered in patients who you put on norepinephrine and they get tachyarrhythmias anyway, because you do see some beta effects with norepinephrine. We want to make sure that we're using an arterial catheter as much as possible to titrate these vasopressors so we know exactly what the patient's blood pressure is at all times. And when we're administering vasopressors, we want to get that in via central line whenever possible. Peripheral lines can extravasate much more easily, cause massive tissue necrosis, and if you've ever seen this, you never want to see it again. I do want to make note that in the book chapter, I do have a very detailed discussion of each vasopressor. So let's go back to our 82-year-old female who's admitted with urosepsis. You've given her 4 liters of lactated ringers, and currently she's receiving norepinephrine at 0.1 mics per kilo per minute. Her blood pressure is 88 over 58, heart rate's 115, urine output is up to 40 mLs an hour, and her lactate is 1. So which of the following is the next best step? Add vasopressin, change her over to phenylephrine, recheck her SVO2, or place a central line for IV access. Don't cheat. Yeah, so place a central line. So why? Patient with sepsis, let's think sepsis bundles. She's already gotten fluid resuscitation. She's on a low dose of norepinephrine. Her MAP is at goal. Her urine output's up and her lactate is down. Good job. No reason to add any more vasopressors to her. No reason to switch her current vasopressor that's working and not causing tachyarrhythmias. No reason to recheck SVO2. You've already got a low lactate. And the next thing is really to place a central line for IV access to give those vasopressors through. Next, let's talk about corticosteroids, another controversial topic. We don't really have a whole lot of black and white topics in critical care. So critically ill patients, we know a lot of them have adrenal insufficiency or something called critical illness-related corticosteroid insufficiency. Glucocorticoid supplementation may be beneficial in certain patients, and we're still trying to figure out which patients those are. Used to be that we would do what's called a corticotropin stimulation test, where this is not recommended anymore, but again, you still see it every now and then. We'll administer a large dose of cosinotropin and check a baseline and then 2 more cortisol levels and see if there's an increase, see if the adrenal gland can actually respond to the cosinotropin. If it could respond, then we would say those people are responders, they do not have adrenal insufficiency, and their adrenals work just fine. We don't do that anymore. We just kind of give steroids if they're indicated, and we have 2 different guidelines that tell us when this might be. So SSC, or the Surviving Sepsis Campaign, they come out with all the 3-hour and 6-hour bundles. They recommend against using hydrocortisone if you've given fluids, you've given vasopressors, and you're hemodynamically stable. If you've given fluids and given vasopressors and you're not hemodynamically stable at that point, they suggest using hydrocortisone at 200 milligrams a day, typically 50 milligrams Q6. The American College of Critical Care Medicine, their guidelines say consider hydrocortisone in patients who respond poorly to fluids and vasopressors, so it's semantics, basically the same thing. They add in the recommendation to wean steroids when it's no longer necessary. Surviving Sepsis Campaign doesn't make any comment on weaning of steroids. And of note, the clinical trials that went behind these statements are in the chapter. So, back to our 82-year-old female admitted with urosepsis. Something went wrong because now she's intubated and in the medical ICU. She's currently on a much higher dose of norepinephrine at 0.8 mics per kilo per minute. Her vital signs show a blood pressure of 110 over 72, heart rate of 108, and her lactate is up a little bit to 2.5. Which of the following is the next best action? Wean the norepinephrine for a goal mean arterial pressure of greater than 65, perform a cosinotropin stimulation test, administer hydrocortisone, or add vasopressin. All right, looks like most of you got it. So here, we're going to wean norepinephrine. So if you calculate out her mean arterial pressure is actually above goal on a very high dose of norepinephrine. And actually a high afterload makes the heart work harder and can actually decrease oxygen delivery. Cosinotropin test, not recommended. We're not going to give hydrocortisone because the person is stable at this point. And vasopressin might be better to give to somebody at lower doses of norepinephrine, but not necessary either way given their high mean arterial pressure. Let's switch gears a little bit and talk about cardiac arrest. And I'm not going to talk again about the full-on ACLS guidelines, but I'm going to mention a few things. For the last 15 years, AHA has really focused on compressions. Compressions. High-quality CPR saves more lives than any pharmacotherapy. Focusing on a CAB mnemonic, so compressions first, then focusing on the patient's patent airway, and then focusing on giving rescue breaths for an unresponsive patient. When an AED or a defibrillator is available, use it as soon as possible. And do not interrupt chest compressions for vascular access, medication administration, or any airway placement. Everything should be focused on compressions and defibrillation. For medication administration, we prefer central lines. Again, that's not always possible. When that's not possible, we like to see something that's a little bit more stable than intravenous. So intraosseous access has become very popular in patient settings. Be very quickly placed in an emergent situation. Peripheral IV or endotracheal administration. Endotracheal administration is way at the bottom for somebody who really doesn't have anything else. If you are going to use medications via the endotracheal route, this is a commonly comes up. There's the mnemonic naval or naloxone atropine. I have vasopressin in gray because it was actually removed from the 2015 guidelines. Epinephrine and lidocaine, so those things can go down in an endotracheal tube for administration, usually at 2 times the dose. If you have somebody who experienced cardiac arrest and you got them back, good job, but now it's time to think about something else called targeted temperature management or therapeutic hypothermia. Therapeutic hypothermia, so cooling the patient down to somewhere around 32 to 34 degrees Celsius for 12 to 24 hours has been shown to not only improve neurologic recovery, but also improve mortality. So we consider this for anybody who's been successfully brought back from a code and remains unresponsive. We can achieve this using any variety of methods. You might see surface cooling, things like the Arctic sun, endovascular catheters, cooling blankets, old school ice packs, and cold IV fluids, any way you can to get this patient's temperature down. Patients will need sedation and analgesia during this period. They still have risk to have both pain and agitation. There's some other things that we as pharmacists have to think about when we see a patient undergoing targeted temperature management. That the biggest thing is shivering. So as you bring the patient's temperature down, they start to shiver, which increases oxygen demand, which is the exact opposite of what you're trying to do. So you have to control it, usually pharmacologically. So there's a number of different things we can give. Sedatives such as Dexmedetomidine, Analgesics. This is where meperidine, probably the only role of meperidine in a hospital anymore. Magnesium, buspirone. The last option that you have is just neuromuscular blockade to make sure that they don't move. The other thing during shivering or during targeted temperature management to think about is glucose control. When we're cooling the patient and they are cool, we see a lot of hyperglycemia. And as we warm them back up, they're at high risk for hypoglycemia, so you have to pay particular attention to their insulin requirements. Of note, shivering is much more common in the period between 34 and 36 degrees. So as you're bringing them down, they start to shiver. Once they're down at 32 degrees or 33 degrees, they usually don't shiver at that point. You're through the shivering threshold. Some other considerations. Most patients, really all patients, are going to have depressed activity of those CYP450 enzymes. So they're going to metabolize things a lot slower. They're going to need a lot lower doses. They also have pretty poor PO absorption, so usually we avoid anything enteral at this point in their care. Electrolyte disturbances are something else you have to watch out for, just like glucose. So as we're cooling, patients start to not really lose electrolytes, but they're going to start shifting electrolytes intracellularly. So potassium, magnesium, and phosphate. During rewarming, all those electrolytes come back out into the bloodstream, and if you're not paying attention, can cause some significant hyperkalemia, especially that can cause poor outcomes. So we need to make sure that we're using a specialized electrolyte replacement protocol during this time, not our usual replacement protocols. So let's go to our next case. 47-year-old male who's supposed to witness VF arrest. He had 2 shocks by EMS, and he's unresponsive in the emergency room. He was started on targeted temperature management and transferred to the MICU. And the next morning, you come in, and they're already rewarming him. Currently, he's on an insulin drip, norepinephrine, propofol, fentanyl, and cisatracurium. So which of the following is going to be the next best action? To increase his glucose testing to Q1 hour, stop his fentanyl, administer some prophylactic potassium, or discontinue his cisatracurium? All right. So this patient's after cardiac arrest, targeted temperature management is being performed, so start to think about what are those complications. So they still need sedation, they still need shivering control, especially when you're rewarming and you're coming through that shivering threshold again, and glucose control. So hypoglycemia, remember, is very common when we're rewarming somebody. Discontinuing the fentanyl would be inappropriate at this point because they're still intubated, they still need some pain control. Administer prophylactic potassium. This is a common misconception. Remember, they're hyperkalemic during rewarming. And discontinuing cisatracurium, while they're going to go through that shivering threshold again, we want to do that after they're fully rewarmed, not at this point. So let's talk about pain, agitation, and delirium in general. This is one of the big things we talk about every day in critical care. So first and foremost, we try non-pharmacologic strategies first. Not everybody needs a lot of benzos, a lot of opioids, or a lot of sedatives. Okay, those can be simple things like redirecting the patient, making sure that the lights are turned on during the day and turned off at night. Providing them with music, trying to make sure that they get sleep and we're not bathing them at 2 o'clock in the morning and taking labs from 2 o'clock in the morning. Non-opioid analgesics for pain should be tried first. We use a lot of acetaminophen. We use gabapentin for neuropathic pain. And when you're assessing pain and agitation, use a validated scale. So those are listed in the book. Sometimes vital signs, so an increased heart rate, increased blood pressure, may be the first cue that you have that the person's in pain. Some other general considerations to think about. Use intermittent PRN first. You don't want to commit somebody to a continuous infusion that's a lot harder to stop than it is to start, when you can just sometimes get by using a couple PRN doses of a sedative or an analgesic. If somebody is on a continuous infusion, they have something coming up that is particularly painful, say a chest tube getting removed or a procedure, you can still give them a little bit of bolus on top of their continuous infusion. One of the big things in the last 15 years now for critical care spontaneous awakening trials. So shutting off all the continuous infusions every day has been shown to actually decrease ICU length of stay, ventilator days, as well as mortality. This allows for reassessment of do we still need these drugs or do we still need these drugs at these doses, and it prevents the drug from accumulating. We operate by what we like to call an analgesic first strategy. We recognize that pain and discomfort are usually why people are agitated, so we should be using analgesics first. So opiates are also sedatives. We call it analgosedation. We always target a light amount of sedation. We don't need the person to be completely unconscious. We want them at least a little bit interactive. So there are some times when we do prefer heavy sedation. So if somebody is on a neuromuscular blocker, we do not want them to be awake at all. We want them to be out because we do not want them to remember not being able to move. Patients in status, patients with very high ventilator settings, patients who are comfort care, patients who have a very high intracranial pressure, all of those patients are also ones that we would keep very deeply sedated. Utilize protocols. Protocols are very important, and they're seen in many ICUs to have regular interruptions in the infusions, and also when you're using all these opioids, don't forget about a bowel regimen. So what do we generally use? We see 3 narcotics that we typically use in an ICU patient. So morphine. Morphine has a disadvantage of causing histamine release, which can cause some hypotension, and also has active metabolites, so very not a good choice in patients with any kind of renal disease. Hydromorphone has no active metabolites, relatively short-acting. Fentanyl doesn't cause histamine release. It's usually very good for patients who already have a low blood pressure. It's short-acting with single doses, but it has what we like to call a contact-sensitive half-life. So the longer you're on the infusion, the longer the half-life, because it's very lipophilic and starts depositing in tissues. So it sometimes can take people a long time to wake up from a fentanyl drip. The other thing that is very popular right now and increasingly popular that I added in that's not in the text is the use of ketamine. Ketamine is not only a mu receptor agonist, but also an NMDA antagonist. You don't get any respiratory depression from ketamine, so it's a very attractive option. It's both an analgesic as well as a sedative. It's very useful in people who are chronic opioid users and they have very downregulation of their mu receptors. Its half-life is relatively short. You don't need any renal adjustment. There's no histamine release. It can be given as bolus doses or continuous infusions. The one downside is the dissociative or emergence reactions that you get from it. Typically, the doses we use in ICU patients, you don't see this. If it was going to happen or you think it might happen, you can control that usually with benzodiazepines. Speaking of benzodiazepines, so we have 2 that we primarily use, lorazepam and midazolam. Lorazepam is nice if somebody has any kind of kidney or liver dysfunction because it still has predictable pharmacokinetics, whereas midazolam, once you introduce any kind of liver disease, any kind of kidney disease, usually the half-life is very much prolonged. Lorazepam at very high doses, there's an additive called propylene glycol that you can sometimes see propylene glycol toxicity. Midazolam does not have that additive. Midazolam, however, you will see drug interactions, so if people are on 3A4 inhibitors, again, they might take a lot longer to wake up. There are active metabolites with midazolam, and just like fentanyl, it has that contact-sensitive half-life, so it likes to deposit into tissues. Other agent is Propofol. So the PAD guidelines, pain, agitation, delirium guidelines from the Society of Critical Care Medicine, suggest using non-benzodiazepines over benzodiazepines. So that means drugs like Propofol and everybody's favorite Dexmedetomidine. So Propofol is nice. It has a rapid onset and a very short duration. If you can turn it on and it goes on, you can turn it off and it's gone. It does, however, cause some hypotension and some myocardial depression. So you can see some increasing low blood pressures. It has no analgesic activity, something we have to remind our nurses all the time. Just because the patient is unconscious and not responding on a large dose of propofol does not mean that they're not feeling pain. They just can't express it because they're on a lot of propofol. It's in a lipid emulsion, so we have to watch triglycerides, especially prolonged infusions or higher doses, as well as we have to talk to our nutrition colleagues about making sure they're accounting for the amount of calories that the patient's getting via their sedative infusion. PRIS, or propofol-related infusion syndrome, it's rare. It's basically a complete cardiovascular collapse. It's usually more associated with very, very high doses for prolonged periods of time and much more common in the pediatric population. So dexmedetomidine. So again, our guidelines suggest using things like dexmedetomidine or propofol over benzodiazepines. The advantages to dexmedetomidine is that there's no respiratory depression. I can put any one of you on an infusion of dexmedetomidine right now and you'll keep breathing. Its adverse effects are usually bradycardia and hypotension. Those are more common during a bolus dose. Most places, most institutions do not bolus dexmedetomidine anymore for that reason. And has a much lower risk of ICU delirium than any of our other agents. So let's talk about a case. So we have a 62-year-old male. He's admitted to the surgical ICU after a complicated Whipple. He's intubated and sedated on fentanyl at 3 mics per kilo per minute. He's become increasingly agitated overnight. His RAS is positive 2. His CAM-ICU, which we'll talk about in a minute, is negative, so he does not have delirium. His pain score is 3. Blood pressure is 120/70, heart rate of 88. Which of the following is the best and you're going to see this a lot, best action or addition for this patient. Sometimes all of these things look appropriate, but which one is the best? See a lot of non-committal people out there. So this patient is agitated. They are not delirious, and their pain is well controlled. Their vital signs are all normal. So which agent do you choose? So we want to choose an agent for agitation, so hydromorphone we're not going to use. And the question is, do we use a continuous infusion or do we use PRN? So one of the first general considerations is use a PRN drug first. This patient may only need one dose, and then they're fine. So why commit them to a continuous infusion that takes 3 days to get turned off when you can use a few doses? If the patient requires a lot of those PRN doses, then that's the time to start switching over to a continuous infusion. So let's talk about delirium. Delirium is an acute change in cognitive function. It's delirium in an ICU